Franny French, Director of Community Relations and Development at United Counseling Service. The short documentary that we're going to see tonight tells the story of the overdose of a UVM student, Will Gates, which sends his father, Skip Gates, on a mission to educate the public on not only the dangers of opiate abuse, but how we deal with it as a society. A panel discussion and community forum will immediately follow and be moderated by Andrew McKeever, News Director at GNAT TV. Tonight's screening is made possible by Vermont PBS, and the film was produced by the U.S. Attorney's Office, District of Vermont. A committee of community members and organizers came together in November to plan an event to address the problem of opiate abuse in our community. Representatives from the Collaborative, Fed Up Manchester, GNAT TV, Manchester Community Library, and United Counseling Service have met regularly since then. The committee decided to focus this first event on prevention, education, resources, and strategies geared toward youth. And we hope that other events will follow tonight's. GNAT TV will be taping tonight's program, and we thank them and all of you for being here tonight. Thank you.
My house is always the place where nobody was there, where it was okay to have parties.
Began with alcohol, drinking with friends.
I mean, I definitely went to parties and had fun.
Just partying, wanting to fit in, just like any other kid.
We want to think that there's a logical process that's going on. For young people, there is no logical process. Their behavior is impulsive. They don't think logically through a process.
In the beginning, yeah, I got high and it was fun.
Nobody ever plans on, going farther than that, but, one thing obviously leads to another.
And they think to themselves, they didn't tell me I was going to experience this. They didn't say it was going to feel good. They told me it was bad. Therefore, everything they've told me about substances has to be called into questions. So then when they take a drug that has some legitimate greater risk, they're less afraid to consume that substance.
I already tried this one thing. What's the next gonna hurt?
Once I found opiates, that was obviously the last step.
You will become consumed by it. It will control every part of your life.
There's gonna come a day where you're not doing it because it's fun anymore, and if you think that you can just walk away and put it down, you're kidding yourself, because you can't.
You will lose friends. You'll lose touch with family.
There's no control, and the scary part is you lose control without realizing it's happening.
People won't like the person you will have become, and neither will you.
This is not it, your life doesn't stop just at high school. There's so much more to life.
As a society, we have done a disservice to young people. We go to this place where we talk about the fact that drugs are dangerous, you can die from taking drugs, all drugs are bad, don't do drugs.
I remember when I was 13 or 14, the first thing that I said is, you're not me. You're not me and I'm not you, and that's your story.
The more teachers, parents, anybody told us not to do something, we did it. We wanted to, mainly curiosity. We want to know why they're telling us no. We want to know why they're telling us we should not do it.
Of course I'm sad he's gone, and it hurts all the time that I lost my best friend and my brother. But I'm also angry that he thought that he could do it. He thought he could do it, get away with it, and be okay. But that's not the case. That's definitely not the case.
Okay. Thanks for coming, everybody. The purpose of today's conference is to discuss developments in heroin prosecution and the heroin and opiate prescription medication problem here in Vermont more generally. Skip is here today to discuss with you the impact this has had on his family. We're really here today to talk more about the education. With Skip's help, and the collaboration of a lot of other people as well, we've developed a public service announcement that highlights the dangers of narcotic, opiate, and heroin use. With that, I'd like to play the public service announcement.
My son William is an extremely passionate person, hence his success in ski racing, his success in the molecular genetics major at the University of Vermont. It's that same passion that convinced Will to try heroin. He was found found dead the morning of March 23rd from a heroin overdose. I have had friends, very good friends, ask me the question, what would you say if you could talk to Will again? I would say, I love you, Will. And soon after that, I would say, what did you think you were doing? What I want people watching this to know is that you might be the brightest guy in the world and the best skier, but you're mortal. This can happen to you. Please don't make your friends and family have to live the unthinkable. And I am without one of the most remarkable people I have ever known in my life because of it. And it kills me every day. I'm only giving you this information to let you know that Will is probably similar to the kind of person that you guys are. He loved the edge. He was a ski racer from grade 3. He lived to ski. He loved it. One of the things his brother and I did was to spread some of his ashes on Sugarloaf, which is his favorite hill.
There hasn't been a day where I haven't thought about it, and like it might have taken his life, but it took part of all of ours, I think.
He was in many ways my hero. I know his brother and sister look up to him tremendously to this day.
Every time we'd go skiing, we'd race down the hill, and he'd usually win because he was a better skier than I was. But I was pretty close behind. But this year, I kind of lost interest. It doesn't really interest me. I don't know how to explain it too well.
I never knew anything in human experience could be this hard, and that's from the bottom of my heart. It's beyond comprehension. I never knew a human being could feel this much pain. It has redefined the rest of my life.
For the first time in my life I've ever seen my dad have tears in his eyes. You know, seeing his son like that, I couldn't imagine seeing my child like that. I mean, skinny, face sucked in. I mean, you could just see big dark circles under my eyes. I looked like your typical junkie.
But more than anything, from a standpoint of education, people need to understand how incredibly dangerous heroin and these OxyContin pills really are. You may think that you're just buying onto a short-time high.
I tried it, and that was it. I got that first high of that sinking feeling of just, you know, everything else shut the world out and just laid back and just let it take me over. And I had things, and within a year it was all gone. It's all gone. House, car, everything.
Other things that are important to most people, they took a back seat. You know, it's like if you've got a certain amount of money and you pick between getting something to eat that day or getting drugs, you're gonna go with the drugs.
That is not a decision. I look back now and I kick myself in the ass for all the bad decisions I made concerning drugs. There is no good decision with drugs.
A lot of the people that you think are your friends aren't going to end up being your friends.
You know, once the drugs are gone and you realize that everybody else is gone too, it's pretty, I mean, it's not a good feeling.
Nobody wants to get high just by themselves. I mean, eventually you will if you have to, if it comes down to, you know, your last fix between you and them.
It's horrible to think, you know, all right, well now I'm all alone and just have to face that reality that the only people that you thought were your friends just were there because of the drugs.
I'll get to a point where, you know, I'll do what I need to do to get that feeling.
Right now, in the Chittenden Clinic, 80% of the clients who present for treatment identify prescription medications of all types as their primary drug of abuse. It is not in the economic or social policy interests of the state of Vermont to continue to underfund opiate addiction treatment.
Attitudes of permissiveness, peer pressure, poor decision-making to begin with, there's not much to stand in the way of that very first hit or that very first pill or that very first foray into something that could have, and in many times does have, tragic consequences for someone's life.
And people are engaging in low-level crime to support habits of 2, 3, 4 oxy-80s a day, and the amount of crime that is required to support those habits is significant. because they have a stamp of approval for use in one respect by the FDA, the kids think that they're not dangerous.
Taking the drug outside of a legitimately prescribed prescription on your own now moves the consumption of a safe drug into an unsafe way of consuming the drug. And I think that's where logic comes in. But again, young people particularly don't necessarily think logically. As a young person thinking this is a safe drug because it came from the pharmacy, I know what its dosage is, I can take it and it's safe. The reality is that consumption can lead to untoward outcomes.
Oxycontin's the same thing as heroin, really. I mean, indirectly, it's synthetic heroin. And once I was already doing Oxycontin, just knowing that it was synthetic heroin, I guess made it okay in my mind that, I mean, I'm already doing synthetic heroin. What's doing a bag of heroin gonna hurt, you know? Hell, it may even get me higher. But it didn't.
It was more of a financial decision, not having a lot of income and just, finishing up high school and working minimum wage job. It's cheaper to buy a bag of heroin.
Virtually every individual that I've known who's been addicted to opiates is virtually a day doesn't go by when they don't think about opiates. If we encourage young people to think and to feel from the earliest age, as opposed to believing that we can think for them or feel for them, we'll be in a much better position for young people to make decisions, which ultimately will affect the rest of their lives.
Nothing is a simple decision, but the decisions that you have to make, especially the real difficult ones, are some of the most important ones. You really need to stop and think about where you're gonna be with that in 6 months, a year. I mean, it can bring you to some horrible places. And I am prime example of what happens when you go that far and how hard it is to come back.
Doing drugs, there's only a couple ways it's gonna turn out, which is you're either gonna die or you're gonna go to jail. Like nobody does it forever and just cruises through life without one of those two things happening.
There's plenty of things for you to look at that can show you how quick it can become a downward spiral that you can't control.
It started off just something that I was doing once in a while. It wasn't something that was something that I planned on, ruining my life with. But eventually, the one thing that it did do for me is it would take me out of that element. Any feeling, whether it be happy or sad, I no longer had to feel when I was on that substance. I could just be.
It convinces you that it's there for all the right reasons and cares about you, but it'll leave you in a second and drop you, just leave you sick, laying on the floor, feeling like you're gonna die. But as soon as it walks back into your life, you forget about the bad and everything's great again. Like it's honestly, the only word I can think of for heroin, opiates in general, is just evil, like pure evil.
It just led to more problems, more hassle, more drama.
This is not a problem that law enforcement's going to solve. The point at which we begin prosecuting someone and looking for alternatives is the point at which we failed.
You might have another chance. You might have a chance to think your actions through. He would always tell me, Dad, I've got it under control. I know what I'm doing. He was right so often that I came to believe him.
I distanced myself a lot because I felt like if I got too close, they might see what was really going on. And I was lying to no end. I was telling them I had a job when I didn't.
Once you get into it, once you try it, you find something you like, and it's that addicting, it is almost impossible to return from.
I don't think it's easy for kids to ask for help. You know, especially within the high schools and stuff now, because you have like a lot of stuff that's going on. You know, you have high schools are really cliquish. I don't know how your school was, but high schools can be really cliquish. You know, like who are you really going to go to with your problem that might not advertise that problem all over the place?
But the reality is recovery is possible, but you have to be willing to take the step to move in that direction.
So thinking back, last week we talked about setting a goal for what you're going to work on in the time that we spend together.
Strengthening life skills and trying to get back into a lot of things that I lost, a lot of things that I stopped doing because of drugs.
It all boils down to helping people believe in themselves, that they can actually gain the skills to achieve everything that they want to achieve in life.
Go for what you want in life and don't let anything stop you. I mean,
those problems are still going to be there once that high goes away. So you're not doing yourself any favors by thinking that getting high is going to help things, because you know, all the stuff that's going on before you get high that's bothering you, as soon as you're not high anymore, that stuff is still going to be there. And most of the times it's going to be even worse because you've put it off or ignored it, and problems don't just go away.
Life isn't always easy, and you know, life isn't always fair, and sometimes there's a lot, and often there's a lot of pain.
My high school class, they were graduating from college, and I was going to jail, which was, that was depressing to think that I had wasted so much time.
I had learned about Burlington from a friend of mine, and he had just said, that the drug scene out there was kind of going on, and that, heroin was becoming bigger, and my habit at the time was becoming bigger, and I guess I wasn't really going to stop until I got arrested or until I was dead. To be 100% honest.
There really is no single story. It's not only people from poor backgrounds. It's not only people from single-family homes. It's not only, people whose parent is an alcoholic. It's not only people who've been forced to move from location to location. All of the stereotypes that I think become easy to grab onto as a way to try to understand this dilemma that we face don't apply. The stereotype that does apply is that we've been conditioned and educated to believe that taking drugs makes us feel good and that it's safe to do it.
I had gone to a place where eventually I found out later on that it was Will's house. Will had some people over that night. I was there with a friend. I met Will one time. Will said, how you doing? I'm William Gates. This is my house. I'm having this little get-together, whatever.
We can help young people make better decisions, more informed decisions. We can help them stay alive. If we do our job well, perhaps we can save at least one other family from having to live the unthinkable. And please believe me, it will have been worth it.
Prescription drug abuse is considered the fastest growing drug problem in our country. And in the past year, 1 in 7 teens abused prescription drugs to get high. Those are extremely alarming numbers.
You take things like OxyContin, when you see children, preteens, being addicted, we have a problem. I want Vermont and what we do in our prevention to be a model for the rest of the country.
We are bombarded as individuals that taking substances to alter how one feels is normative. It's a normal, appropriate behavior. You can't watch television, you can't turn on the radio, you can't open a newspaper or magazine without seeing or being confronted with some advertisement or commercial to take a drug, to make you feel better, to make you feel different.
You try something, you like it, and it's a downward spiral from there. And it took me years and years to realize that and recognize it.
I don't want to minimize the fact that there are some drugs, and opiates are one of them, in which sometimes the first time you take it can be the last time.
There were a lot of people I knew that OD'd, and a lot of them that didn't, they didn't come back from it.
Life can definitely be hard. The decisions that we make affect us and, the loved ones that are around us.
Reach out to people you think might judge you, because I would have been pleasantly surprised had I reached out, because they wouldn't have turned their back on me when you know that they really are your friends and they care.
Right now at 22, I should have been at this point 3 years ago, 4 years ago, but unfortunately I wasted that time. Having to kind of catch up on life, having family around again, and good friends that are there to support you, friends that, don't do drugs, don't want to do drugs, don't want you to do drugs. That all keeps me from going back, because when you get mixed up with something like Oxycontin, you lose all that.
I would say that I'm sorry, but I think that sorry wouldn't be enough. I apologize deeply. I never wanted anybody to die. I never wanted anybody to get hurt. There's been many tear-filled nights in cells that, that I've had to go through thinking about that, I'm sure it's not the greatest thing to see your youngest child get sentenced to 16 years in prison. I don't even know if my parents are going to be alive when I come home. It's one situation that I think of all the time, How are they going to feel if, one of them's on their deathbed and, the only thing they can think about is that I'm in prison.
Instead of going and picking up drugs, if I had just had a conversation with someone or dealt with the problem head on, I think it would have been much more productive, and the outcome certainly would have been better.
I definitely think that friends and close friends can get through. They have to. You have to. You can't. You don't want to lose a friend. He was always there to be ahead of me, but he's not. Doesn't matter how strong you are, how smart you are, how much of a control you think you have over it. You really don't. Definitely not.
Great to see so many of you here tonight. Obviously, it was a very powerful and moving movie, and I think we're going to follow that up now with a very informative and thoughtful, thought-provoking discussion with a group of panelists that we're going to meet in a moment. I found it interesting that that movie was made in 2010, and according to the Governor's Opiate Council, it was recently formed last year. Since in the 6 years following when that movie was made, in 2010 to 2016, opiate-related deaths due to overdoses in Vermont rose by 160%. It's a, kind of a staggering statistic. Another number I ran across yesterday as I was preparing for this evening tonight. Every day in 2016, every day, 175 Americans died from opiate-related deaths. I think we'll get the sound up now. That translates into 62,000 deaths per year. That's more than the number of people who were killed during the 15 years of the Vietnam War. That's more than died during the peak of the HIV/AIDS epidemic in the 80s and 90s. More than died in the worst year of car accidents in the United States in 1972. 44,000 people died. So this problem is way past those levels. Anyway, I'd like to invite our panel to come up now to join me up here, and we'll get the conversation started. We're really fortunate to have this very distinguished group of folks with us tonight, and they're going to bring a variety of different perspectives to this conversation. What we're going to do is give each one of the panelists a question. They'll have 2 minutes to answer that question, and after each question we're going to have like sort of a round-robin, 2 minutes or so conversation for all the other panelists to weigh in on that particular question. So let's see here. Going from, I guess it would be stage right, over there at the end, we have, first of all, Wendy Galbraith, who is with Fed Up Manchester. Wendy represents Fed Up Manchester, Vermont, a local coalition working hard to combat the opioid epidemic through awareness, education, action for change, and support for families and addicts suffering. Wendy has firsthand experience as the mother of a child who suffered from substance abuse disorder. Her son lost his battle with addiction 4 months ago. Next we have Maryanne Morris with the Collaborative. Maryanne is the executive director of the Collaborative, a substance abuse prevention organization. She has a background in recreation and worked with young people at summer camps for many years. Maryanne took her passion for working with young people to the Collaborative in 2003, first as the Extended Day Program Coordinator and then Program Coordinator, and in 2010 she became the Executive Director. She serves on several statewide and regional prevention planning teams, and the Collaborative has led and facilitated Bennington County Prescription Drug Task Force since 2010. Then we have Beth Sawsville, who is with the Vermont Department of Children and Families. She holds a master's degree in counseling psychology from Antioch, New England, and has worked for the past 23 years in child protection and juvenile justice, serving children, youth, and families in Bennington County. The last 7 years I've been as the director. Then we have James Riley with the United Counseling Service. James Riley has been, what, the fan club here tonight. James has been working as a licensed alcohol and drug counselor in the state of Vermont for the past 28 years. He has worked continuously with youth in the Bennington and Manchester areas during that time. And last but hardly least, we have Nissa Walk of the Blueprint for Health. She is an assistant director with Vermont Blueprint of Health, which is an initiative that designs community-led strategies for improving health and well-being. She dedicated her undergraduate studies to behavioral neuroscience after discovering that mental and physical health are intricately intertwined. She earned a doctorate in pharmacology and toxicology in 2006 and has been with the Blueprint of Health since 2017. I'd like to throw a question out to the entire panel and invite all of you to give us your reaction to the film. What thoughts or ideas about prevention, education, strategies, and resources did you glean from watching the film? And Nissa, why don't we let you start?
So when I look at the film, one of the things that was really reinforced for me was the substantial impact opioids have had on our communities across the state of Vermont. And I think that impact is evidenced by how many people are in attendance here tonight. The number of people in attendance tonight, however, gives me hope, because one of the aspects that we are well aware of is that strengthened and committed, connected communities help to reduce the prevalence of substance use disorder.
I think one of my reactions to the documentary is that it just makes me remember, be aware of all the young people that I've been working with over the years. And this epidemic really started in the 90s and has become kind of a tsunami at this point. But I thought it was a good representation in that most people who have this affliction are coming from all different walks of life, and often it has its roots in prescription drug use that starts from injury or some kind of medical condition, and then it takes off from there. The latest research that I've seen shows that 15% of all people who ever take an opioid, any opioid, that could be for a toothache, anything, will develop an opioid use disorder. So I think if we all knew that and were more aware of it as we approach our medical care, that can help. That's a very sobering statistic to me.
I think for me, in working with children and families in our community, one of the things that stood out for me that we've recognized for a long time is that youth need to be connected to positive adults in their life. The young woman that spoke to that feeling of, or distancing that was coming into play for her. And I think that the addiction, as James spoke to, becomes very easy. And so therefore, as adults, I think that we can really have an impact when it comes to prevention.
Thanks. I'll reiterate that it's really hopeful that everybody came out to see and participate in this event tonight, because I think that one of the pillars that the collaborative does its work around is education. So we've all been educated by listening to their stories, and they'll be more educating tonight. And making these connections is another piece. So look around you, and these are the people who you can talk to about this disease and about how to prevent it and what the resources are in this community. When I think about the North Shire and Bennington County, there's always this feeling of, well, that happens to somebody else, and it's not. We've gotten to know, we can see the people with the fed up shirts on. We know who it's happened to in this community. We know, after you leave today, hopefully, who your resources are and who your allies are in the community.
When I'm watching the movie, I'm hearing that the kids are using because they want to feel better. They want to feel connected. They want to feel safe. And I think this is that addictive behavior is not the root of the problem, but it's a symptom of this deep need that the kids have. I see kids so attached to their cell phones and technology and not making connections with each other and having human one-on-one conversations. I wonder how we can integrate things, activities, classes into our school curriculum so the kids can put down the technology and start connecting, like board games, have meditation and yoga as part of the school curriculum, so they can find ways to help themselves feel better when they're feeling bad, find more productive ways to deal with stress than having to reach for drugs.
Okay, thank you all. Wendy, why don't you hold on to that microphone there, because I think we'll throw the first question over to you. Wendy, could you describe for us the most important issues you encountered and the knowledge you gained in your journey as a mother of a child struggling with addiction? And just before I let you start there, just again, we'll have 2 minutes for each answer, 2 minutes for kind of all of you to comment, and move on from there. So.
A lot to talk about in 2 minutes.
And that's very hard. It's a very complicated question, and 2 minutes to give it justice.
On the things that affected me the most. When I first learned that my son was using drugs, I was terrified and paralyzed. I didn't know what it looked like. I didn't know what that meant. I thought he was just had a little bit of a problem, and things would get better. And the stigma prevented me from reaching out for help. I figured I'm super mom, I'm gonna fix this. So I didn't ask anybody for help. I didn't even share it with my family. I was too embarrassed. 8 months of disasters happening. I finally reached out for help and I found that I was not alone. A lot of people were having this problem. So we really need to get rid of the stigma so people can have the conversations, can come out and ask for help. Even the addicts can come out and say, I've got a problem. It's so important to find support. I found support in Al-Anon. It's phenomenal, and you find other people who have the same problems. You have tools where you learn to take care of yourself. And I had to be able to be strong enough to take care of myself so I could survive the roller coaster ride that my life became. It's important to educate yourself with as much information about the disease as you can. I didn't know what I was dealing with. And I came to believe that, and I still do, that it is a brain disease. It changes, the drugs change the physiology of the brain, and it hijacks the brain, and so they connect with pleasure in a different way. Pleasure to them is using it. And once they're addicted, that's the norm. To be addicted, the behavior that's the norm. It's when they don't have the drug that they feel sick. My son came to me, and there was very little facilities in the state of Vermont. I searched in a panic overnight to find. He says, I'm going to detox now. He's on the couch. Where do we go? Who do we call? What do? I didn't know where to start. So I feel it's really important for everyone to be prepared. This can happen to you. It takes, and it can happen to anybody. But to be ready and to have some resources is really important. The treatment situation. So once we finished the detox, because there was nowhere else to go except on the couch, then had to find a place for him to go quickly. And I found that in the state of Vermont, there was very few choices. We were lucky to get in within 2 weeks to a place that gave him 2 weeks. That was it. It wasn't enough. It was barely enough to detox, and with a day after he left, he relapsed. Of course, I believed him when he said, I'm fine, Mom, because he looked fine, but he was still using. And the next few months, it was downhill until it was such a mess that it was unbelievable. Once again, detoxing on the couch and trying to find a good rehab. We ended up in out of state, and I have learned that you need long-term, structured, sober living facility that includes not only the rehab piece, 12-step piece, counseling, ongoing support with jobs, living skills. This could go on a year. They need a year, and there's no places like that. So we need to work together to find new solutions. We don't have to reinvent the wheel. We just have to gather together all our knowledge and figure it out. And even when I thought my son was doing well in this new place, he had 4 months under his belt, and he felt he was ready. He got a job, an apartment, and he was ready to go. And one night he says, I'm fine, everything's great. And the next 24 hours later, I got the call that he had OD'd and died. And it was just like, what? What did I miss? And definitely, we are missing something. We are missing the piece where they're struggling. There's something inside of them, the reason that they use in the first place. And we need to be able to address that with a dual diagnosis. It's a disease. It has to be treated as such. It has to be counted as an insurance that way. And we need funding to take care of it. I'm so grateful that you're all here tonight. It means that you really care. And together we will make a difference. But we have to join together and everybody do their parts.
Thank you.
else in the panel care to comment or weigh in on that?
Yes, I just wanted to talk a little bit about the stigma. In preparing for this tonight, I've talked to some of my active clients who are struggling with opioid addiction. And for them, one of the hardest things that they said was the stigma that's out there. Routinely, they feel judged by people who should be professional and intelligent and understand that opioid addiction is not a product of simple moral failing. It's not even often a choice that a lot of people make. And yet they're treated like second-class citizens. Doors are closed to them, and that's very, very difficult. With that said, the other devastating thing about this illness is that it is hugely difficult for the families. It is not an isolated thing where it's the addict struggling by themselves. Often families are devastated. Often families are directly violated in terms of having money stolen and resources, and the lying and misrepresentation that is part of this disease is extremely difficult. So I would ask people to remember that it is a disease. It's not like any other disease, but judgment is not going to help to solve this problem, in my opinion.
All right, Maryanne, you're next. Your question, what youth substance use prevention strategies and what prevention efforts are happening in our communities and across the state? Could you provide examples of community efforts that you have found to be successful and interesting that have been successful in addressing substance abuse prevention efforts?
Sure. So first I'll say that when you talk about substance abuse prevention, we have strategies that address all substances. So if I'm talking specifically about opioid, it would kind of go across the line. So forgive me if I slip in a strategy that's specific to another substance like alcohol or something like that. But the strategies remain kind of the same, and you'll see why when I begin to talk about them. Providing information and education. So these are messages that you might have seen. Vermont's Most Dangerous Leftovers, and that we're talking about prescription drugs left behind in people's cabinets. In this community and across the state, it's very strong in this community with the Bennington County Prescription Drug Task Force. We have collection boxes in all of the law enforcement agencies in Bennington County. And we've had the first permanent drop box installed at the Southwestern Vermont Medical Center in a small hospital in Vermont. So if you're, like me, a little kind of wary about entering law enforcement buildings sometimes with a boatload of prescription drugs, you can go into the hospital and drop them off there. You might have also seen messages about Parent Up, which is a campaign that is designed to educate parents about how to work with their kids, talk with their kids around substances. Providing education, there is health curriculums installed in the schools in Bennington County for specifically around substance use, and in many of the schools in the North Shire. And I'm unsure about what's happening in the in-between area of Arlington right now, but that doesn't mean that there is not substance abuse education coming from the schools there. Education is provided through parenting classes in the South Shire, down in the Turning Point, the Recovery Center in Bennington, also through the Coalition for the Homeless, and through independent classes at Flickbrook School and in the North Shire area. We also have the program Refuse to Use that the Collaborative does, which educates parents and young people around substances, 5 prevention education events outside of school time. Another thing that we try to do is decrease barriers and increase access. So this is another point where the prescription drug take-back boxes, increasing the barrier of having, I have too much medication in my home. Where can I put it? Another thing that we work with is policy. So here in Manchester, we try to do some policy work with decision makers, businesses, towns, And in Manchester, they have an ordinance for their park that says that you cannot have a prescription drug in your possession in any of the parks in Manchester. That is not your own. Now, it's a minor sort of a thing, because it's also a federal regulation that you're not allowed to, but what it's saying is that in this town, in Manchester, we've made a commitment to try to prevent that type of a thing when there's other healthy behaviors going on. And then some programs. What the collaborative tries to do, and other organizations like ours as substance abuse prevention organizations like Alliance for Community Transformations down in the Bennington area, provide substance-free events for young people. So what strikes me about this film is that the dad is saying he did skiing, he did this, he was into his school major, and he had this activity. Those are all great things, and sometimes, we encourage those healthy behaviors in kids. It is sad that sometimes that's not something that can always work. Look, one more thing, changing policies. Changing consequences is another thing in Bennington. They're doing some work around positive ticketing campaigns so that when young people can get caught doing something good, they get a ticket for that. Volunteering in the community, going to a movie instead of hanging around doing something that might be destructive. And the law enforcement in Bennington provide a ticket that gives them a coupon to somewhere positive, like to go get an ice cream cone or a discount for a movie or something like that. So these are some of the strategies that we work at in this community. But what's the strongest in Bennington are the partnerships. So I think that you've heard that there's a clear, strong partnership with the medical community. There's a clear, strong partnership with schools. There's a clear, strong partnership with law enforcement to do some of these strategies and work together towards increasing the health of our community and decreasing substance use.
Thank you, Maryanne.
I just wanted to add that as part of the Alliance for Community Transformation, which is the coalition in the South Shire, one of the things that struck me about something that Maryanne said that I wanted to emphasize was that a multi-pronged approach is really a good thing. That just because there's a targeted campaign around tobacco or alcohol, for all of the youth who start somewhere and feel better as a result of taking some kind of substance, that it also has the ability to impact that use and abuse long term as well. So I think there is a lot of good work, and connect with folks in your community that are doing that work, because you can never have enough people doing the work.
Yeah, thank you, and I'm just going to follow up. The one thing that we do when we talk about education and providing information, one of our primary messages is open communication. Talk to your young people. So that's a consistent message that we say. There's statistics that say that between 84% and 91% of kids cite that their parents are the #1 reason why they choose not to be using drugs, alcohol, tobacco. And you, as parents who might be in the audience, probably don't feel like it's that high. But they're listening, so we want to give you the right information so that you can continue those conversations with your kids any chance that you can. Your kids and maybe another kid who might not have an adult who they could talk to.
Okay, thank you, Maryanne. All right, Beth, you're up next. This is a point, this question goes to a point that's already been discussed a little bit, but I'm sure there's much more to be said about it, and that's the question of stigma. How does the stigma of drug addiction affect the addict, the family, and the general public?
So I think you're right. We have touched on this a bit. I think that the film also did a nice job of illustrating some of the stigma and impact on the addict themselves. And James also alluded to this as well, in terms of the public perception and the impact that has on the addict, in terms of the amount of time that it may take for them to reach out to someone. I think for youth who are using, what we see oftentimes is, and Maryanne just spoke to this too, is those adult connections that if you're a parent who says, well, they're just a teenager or they're just going through a phase, and you choose not to ask, then, the results of that could very well be detrimental. I think that what we see in terms of child protection and youth justice in Bennington County is that youth aren't always happy with adults being involved in their lives more than not, but down the road they will cite that as being an incredibly positive thing for them. I think that for parents, what we hear a lot of times is the frustration or desperation, where did I go wrong, the self-blame, and I think that the more that we can be involved together in terms of approach and education, the better off that you all are in terms of providing that support and guidance for youth that you're involved with or parenting. In terms of the society, I think that this speaks volumes about the direction and how far we've come in terms of wanting to know, wanting to be educated, wanting to be part of the solution instead of part of the problem. So I, echo what others have said about the amazing audience and turnout tonight. I think that this room would not have looked the same a few years ago when we were publicized in the New York Times. So.
Any other members of the panel who care to weigh in on that one?
I'll say something about it. I mean, to kind of continue with what you're saying, Beth, I work with children, teenagers, families, foster parents, all kinds of people. And one of the devastating things about this epidemic is the number of very young children that are being brought into our foster care system. And not just that, being parented by their grandparents, often whoever could step up, because the young people, our young people, are in an epidemic. And the parents are cyclically having their children taken away, they get them returned, but this is a very difficult disease to deal with, and often there's a continuous kind of going in and out of different care in different households for our young children. So that's another reason that this is such a huge, huge crisis.
So just to piggyback on that, to give you a sense of volume. So in Bennington County in 2017, 62% of children ages 0 to 5 who came into care of that, so 62% of the children who came into care were 0 to 5 years old. Of that 62%, 50% were due to addiction.
Okay, well, James, you're next. This is a question that fascinates me. What is the link between prescribed drugs and addiction?
Okay, the link is a very direct one. I mean, this crisis had its roots in the late 90s. And, it's not my job to point fingers at particular pharmaceutical companies or specific drugs, but certainly we heard in the documentary about OxyContin, and that was one of the things that launched this epidemic hugely. And part of it is that the company that launched it did a fantastic job of marketing and educating doctors in a way that I think initially they thought was responsible. OxyContin was thought to be a revolutionary chronic pain management drug because it provided time-released pain medication in an opioid form. What was unpredicted was that people who developed dependence on it would quickly understand how to bypass the time-release mechanism and begin to abuse it. But it's certainly not just OxyContin. At this point, we have a whole host of different prescription drugs, which include things like Vicodin, Percocet, Roxycodone, oxycodone, And the list goes on, and it behooves everyone to educate themselves as to what they are. As was talked about earlier, these things cannot be laying around, because if the person who gets a hold of them is one of that 15%, then inadvertently they have just launched a career of addiction, or you have, by leaving it laying around. So that's very important. But it's not as simple as just saying the big pharmaceutical companies are to blame, although there have been huge class action suits against companies that were proven to continue to heavily market opioid drugs despite huge evidence. And huge settlements class action suits have been settled for $770 million. The figures are gigantic, but they are nothing compared to the amount of money that big pharmaceutical companies have made off of these drugs. So that's something that we all have to deal with and think about. And going to what was said in the documentary about drugs and us as a culture, is that we've come to believe, apparently, that if we have any kind of problem, there should be a drug that will fix it. And as a person who tries to teach mindfulness-based chronic pain management skills, believes in different alternative therapies that are now coming forward, like acupuncture and other modalities, there are many ways to deal with the pains, medical and otherwise, in life. And they do not include medicating them into oblivion with a very effective pain reliever like an opioid. But that is a huge part of the problem. When you look at statistics like the fact that prescribing of opioids nearly doubled for our adolescents and young adults between 1994 and 2007. Now that is very, very concerning. Okay, and that trend now, the news is not all bad, because now it's taken time, and these things do. I've seen it in my agency where it takes so long just to set up programs to help people with this disorder, like Suboxone programs. Very, very difficult, but now we finally made some progress with setting very clear prescriber guidelines that are strict and being followed, and both prescribers and patients are getting re-educated. For the first time in a very long time, we're finally starting to see some reduction in the opioid prescription numbers, but it has taken years for us to get there. So that's the good news, but hopefully, if people have more awareness, then that's what's really going to make a difference. And we need to stop looking to drugs or substances to fix our problems, in my opinion.
Anyone else in the panel care to add to that, or? Okay, well, in that case, Nissa, you're up next. What are state and local county organizations and businesses doing in response to the opioid epidemic?
So I was really humbled to be asked to answer this question, and I'm so thrilled to hear that many of the initiatives have already been covered, because frequently, given my profession, I'm never certain how much is actually available to the community in terms of awareness of what's happening. And what I've heard here tonight are many of the initiatives that the state is leading have already been covered. So the Parent Up program by the Vermont Department of Health is a tremendous resource for parents who are seeking information about how to talk with their children around substance use and look for symptoms in case they have concerns. What we frequently found is that often offering parenting classes doesn't necessarily provide the information that people are looking for in a format that they're willing to accept. And so by creating that resource that allows parents in the comfort of their own home or wherever they may be, discern the information that they're looking for to support interactions with their child. So thank you, Maryanne, that was wonderful. We've already touched on the acute and chronic rules that went into effect, looking at limiting exposure to opioids, and that did include both provider and patient education components. That has also contributed to the reductions we've seen in exposures to opioids. Beyond just reductions in exposure to opioids, it also asks providers to consider other non-opioid, non-pharmacologic approaches to treat pain. It also included components for patient consent to make sure that patients were educated and understood the risks associated with opioids. We've made enhancements to the Vermont prescription monitoring system, which help providers improve the care that they provide to their patients by being able to see what other prescriptions may have been written for their patient and provide the best care possible with all information available. The enhancements have allowed providers now to see what prescriptions have been written for neighboring states, and that was largely due to the requests of providers to have that full picture of the prescriptions their patients have been prescribed. We've seen SBIRT implemented across the state in varying forms. SBIRT stands for Screening, Brief Intervention, and Referral to Treatment. And this has happened through grants from the Substance Abuse and Mental Health Services Administration in some communities. It's also happened, although it may not be apparent, through the communities across the state that are participating in the Women's Health Initiative, where medical practices and community partners have joined together to focus on identifying categories that impact health. And in those partnerships, they have started to screen for pregnancy intention, for depression, for substance use disorder, for food insecurity and housing instability, as we broaden our definition of the factors that influence health. Once those screens are in place and have identified a need for any of those categories, the relationships with community partners are developed to ensure that we can meet the needs that we've identified. We've increased our drug disposal locations to ensure that we can remove the supply of opioids from our communities in a safe fashion that is also responsible for our environment. With regard to treatment, we designed and implemented the hub and spoke model, which has gained national recognition. And although our efforts will never be enough, and we won't stop, and we will continuously implement quality improvement, we have expanded our treatment capacity more than any other state in this nation. We convene learning sessions to provide additional education for spoke staff, for hub staff, and for all providers to ensure that we're moving best practices forward in a consistent way. And we have our recovery centers throughout the state who are providing access to naloxone, who are providing on-demand recovering support and crucial services that very frequently fill the gap within communities when people cannot immediately find the care that they're looking for. So that's just a few of them.
Before we turn things over to our audience, any other comments from our panel here? Last question before we...
I think I just wanted to add from a local perspective, one of the other things that we've implemented at DCF Family Services is that we have now a substance abuse screener co-located with us that works very diligently to ensure that folks that are interfacing with our system have direct and more immediate connection to the mental health system and treatment resources. That person works very closely with United Counseling and is able to make sure that our young parents that are involved in our system are connected as soon as possible.
So in the projects that Nis is talking about that are happening at the state level, there's also impetus to have these conversations at the local level so that it strengthens what's happening locally. So for instance, the Vermont Prescription Drug Monitoring System, with the task force that I talked about, and then with an internal opioid team at the hospital, they can look at those numbers for Bennington County specifically and brainstorm for ideas on how to improve them in our community. So the task force has been able to look at these numbers and say, maybe we need to educate dentists and veterinarians on what's happening with the opioid issue in this community, and so that's what we did. So that's just an example of the project that's happening at the state level getting implemented with a different twist to be culturally appropriate for Bennington County.
Okay, great. Well, as advertised, now it's your turn. I got several questions already turned in here on the index cards, but I'd like to see, like maybe start it off if there's some folks in the audience, yes there are, who might wish to ask some questions, and I'll try to get to as many of these as we can.
Good evening. My name is Tyree. I'm from Vermont Adult and Teen Challenge. Actually, to what you had said, we actually do have long-term recovery here in the state. I represent a program. We are a 15-month residential drug and alcohol program based in Johnson. We have the opportunity, actually, this April, we'll be opening our first women's facility also. And so we do have that resource here in the state. We are nonprofit, we are faith-based, and we offer long-term residential care. And so as a resource for everyone in the room. On that note, what is the openness and the research to working with the faith-based community in terms of finding our solution? Which I must say that we have nationally the highest success rate within the recovery community sector.
Did everyone have a chance to hear that question?
Okay. So the system that we're striving for is comprehensive, coordinated, and patient-centered. So ultimately, it would come down to the decision of the patient. But what I can tell you is that the national guidance includes the faith as a crucial sector for contributing to community-level change.
Thank you. Okay, so more hands up there. Yes, ma'am.
I heard Maryanne talking about the need to make sure that we are not leaving excess medications lying around. There's talk about places where you can go to drop off these medications. And I'd like to hear a little bit more about what the gentleman on the panel was saying about regulations for prescribing, because as every parent in this room knows, when your child has an earache, you get 7 days of amoxicillin, and when it's done, you're done. You don't have any extra amoxicillin in your bottle, and it's over with. But when your child hurts their shoulder and could benefit from a day or two of something stronger, you walk out of the doctor's office with a prescription for 30 days worth of medication. So I'd like to know more about what's being done to reduce that overprescribing, not only when you don't need an opioid, but if the doctor really does feel that you need an opioid, for them to just give you a day or two instead of 30 days.
May I respond to that question? My name's Kelly Filippi. I'm a registered nurse at Southwestern Vermont Medical Center, and I spearheaded a project a couple of years ago, to answer your question, to look at decreasing the amount of opioids that were going out into the community by having the provider prescribed an accurate prescription, if any, for opioids. Anyway, to make a very long story short, it was a multidisciplinary collaboration between doctors, pharmacists, nurses at Southwestern Vermont Medical Center. We looked at what we were doing and why we were doing what we were doing. And to go back to what Mr. Riley said, opioids were being prescribed because pain became the sixth vital sign back in the 90s. JACO, who's the governing agency of hospitals, made pain basically a vital sign, and providers had to deal with patients' pain. So our project looked at what we were doing, why providers were prescribing so many opioids. And when we peeled back the layers, what we found was they were doing what they were doing just because. that had always been their practice and nobody had questioned it. So now with all this awareness and, the overdoses and Vermont being, in the media and the New York Times, we really took a good hard look at it. And through this multidisciplinary collaboration, our providers at our hospital started prescribing differently. And they made it patient-centered, and they looked at the patient, and they had a communication with the patient, and didn't just write prescriptions just because that's what they were doing.
Right, well, but is there any kind of regulation?
Yes.
Being nationally?
Yes. Yes. So Vermont, back in July, as Nissa had said, put in regulations for acute pain. So for Vermont. Not nationally, but the work that we had done at the hospital is being looked at by other states. Like Maine has approached us to hear how we got our providers to change their prescribing practices. So the word is spreading. And for our little hospital to do this great work is huge. And our providers have changed their prescribing practices before the regulations went into place.
Thank you, Kelly. Erica Martins, our state's attorney, looks like she has a question.
Well, I just wanted to ask the panel, we've talked a lot about prescription drugs and prescribers and the regulations on those, and don't leave prescription drugs around and don't get too many. Let's talk about heroin. Can you talk about, I would expect that at least 4 of, I'm not sure what some folks' experiences with it, but the movie and the cases that we're seeing and the people that are dying from heroin overdoses or heroin and fentanyl. And I just wondered if you could talk about the prevalence and the readily available sources of heroin in our little community.
Who wants to take that one?
Well, I can say something about it. As was pointed out in the documentary by the young woman, at some point what happens to people is that they develop opioid use disorder, and they start needing more and more because it's a physically addictive, tolerance-building drug. And the cheapest opioid out there is heroin. And so, it's heartbreaking to see people across all spectrums. Loggers and blue-collar, white-collar, high school children, everyone. The journey is that they start out with prescription pills. Almost all of my clients tell the same story. It's the same story with different details. And so what happens is they end up buying heroin. They end up on the street buying heroin. Many of them never quite make the final jump to using IV heroin and shooting with needles, although some of them do. And it's shocking to some people when they hear that someone can be shooting 50 bags of heroin a day. But it's a tolerance-building drug, and the fact is that people just develop a tolerance to it, and to the point where they could take more and more. What would kill one person barely gets the other person high anymore. So what I've seen is that, and when we see examples of huge, people here all remember a few years back when they found 40 kilos of heroin on the street in Manchester in a van in front of a local establishment, and there have been huge busts ever since. But the answer to me is education and prevention. Interdiction in most developed countries has never gotten more than 1%. So we have to change our mindset, and the desire for it, the demand for it needs to go down. As some of my more innocent clients say, well, you know what? You can arrest a couple people and there's going to be 4 more guys there 5 minutes later to make the money. So that's what I've seen a lot in terms of heroin. That's the journey that people make. And those people, most of them say they would never, ever have imagined themselves using heroin. Never. They never intended to. It was never their intention. But when your choice is getting sick, extremely sick, and going into withdrawal and trying to kick the opioid, and buying the cheapest form of opioid out there, a lot of people end up using heroin in my experience with the clients that I've been working with.
So to leverage my partnerships, which I like to do best, I would just like to see if maybe Stephanie Thompson, who's the DEA high intensity drug trafficking person for our area, I wanted to spell it all out for everybody, has anything to add to that question.
So what we've been seeing based on the 2016 data, we're still waiting to have the 2017 state data come out. Looking at the fatal overdoses that we had, heroin and fentanyl both came in tied. So we're seeing an increase in fentanyl being put into the heroin that's out on the market. A lot of times the individuals that are using are not aware that they're getting fentanyl. In other instances, I've heard anecdotally from a number of folks, they are using it knowing that it's fentanyl. It's less costly, and that's a route where some people, they're recognizing that the risk of overdose is much greater. So they're trying to be more proactive, keeping Narcan on hand, making sure they're not using alone, really trying to be as cautious as they can, but as our overdose numbers have shown that, we're still losing a lot of people as a result of that. Certainly law enforcement's doing what they can on the interdiction side, but as it's been said before, really the best thing that we can do is stop the initial use and trying to educate more people to not begin using opiates in the first place, because this is a road that we've been seeing this progression to heroin, to fentanyl. That wasn't the case in previous heroin epidemics. Thanks.
Thank you very much.
I apologize, but
yes, sir.
Not only do I work for Manchester, but I also work for the Drug Task Force. And I've been involved in numerous controlled buys. I had to put one off tonight so I could be here. The problem that I see is that I have a lot of bonds with people who are suffering from heroin and fentanyl addiction. And the problem that we see, or I see, on the road is that they're not getting help. And the problem that I see is that I'm having such troubles with the fact of here I am forming numerous bonds with a lot of my informants who are resulting to black market Suboxone. And they're taking razor blades and they're cutting an 8 milligram sublingual strip to get off heroin because they can't get into your programs. So, and now I'm faced with the fact of having to remove them from my program because we have a contract, but yet they're trying not to get high on heroin and fentanyl because, just recently we just did a large case where there was numerous bags of fentanyl. And so with that, my question is, why are we not getting these people, members of our community, into your programs to get help?
Well, I'd like to say something about that. One of the most frustrating aspects of my work with people with this substance use disorder is that, as you're pointing out, the immediate help of getting into a program, for instance, a Suboxone program, which is a medication-assisted treatment to prevent withdrawal and treat opioid use disorder, the waiting lists and the waits to get into these programs has been very discouraging. Now, we've heard that we have one of the best models or systems in the country. My experience as a clinician has been a very frustrating one. I can't think of medical disorders other than organ transplants where we put people on waiting lists when they have a life-threatening condition that could end them either imprisoned or dead. And yet it happens regularly. And one of my biggest frustrations is to call multiple programs with my clients to try and get them in for treatment, and it's not available. Part of the problem is that it seems that there are many different methods being used out there, I think with good intention, but there's not a uniformity of programming in terms of medication-assisted treatment yet in my experience with my clients. And I think it's a disgrace when someone is crying out for help and they can't get it. What you need to realize also is that with this particular client population, they are in some ways like whales. They often will come up for air and ask for help, and if you don't help them when they come up, they are going back down. And sometimes they're going to die. So it is a frustration, but with that said, I think the programs are getting better, but you've got a mixture of nonprofit organizations like the one I work for and for-profit treatment organizations that have different standards and different ways that they're doing things. So it is very frustrating, and it's still very much a work in progress from my limited point of view.
Oh my goodness, so many questions. So let me just say, we are continuing to evolve the programs. This is a relatively new field. Best practices are emerging. We still have work to do, and I hope you heard me say that earlier. One of the aspects that we found to be tremendously helpful is in some of our communities, they have formed centralized triage teams to be able to take those calls from one phone number and be able to help people get into the programs they need. And that is where we are trying to move all of our communities. We do understand that we have progress to make.
Yes, Mr. Drunzik, you've had your hand up there for a while.
Bill Drunzik, relative to this issue of treatment in facilities, programs available, is some of this related though to financial resources, and that we are having difficulty recognizing the need and putting the necessary financial resources in getting these programs in place?
There's a financial component. There's also a human component in terms of we traditionally have had difficulty recruiting the staffing that we need specifically to treat this use disorder.
Yes, sir.
Hi, my name is Robert. I am with Vermont Adult Teen Challenge also. We're a national and international organization. We are nonprofit. We are faith-based. Recently, we've seen an increase also in the uses of fentanyl. So I'm wondering why we're not looking at the pharmaceutical companies that are producing fentanyl from a legal perspective. And also, Teen Challenge, if someone doesn't have money to come into our program, I'm the one that takes the call. I will let that person come in. I will hand out my business card right here tonight. We don't have a waiting list. If our facility is full, we can send people to Rhode Island, Massachusetts, New Jersey, Connecticut. Our doors are always open.
What age groups?
Okay. What's that?
What's your age groups?
Age 18 and up. It's actually called Vermont Adult and Teen Challenge. So there's an opportunity, if someone needs help, just call. Okay, a lot of people don't even know. We have one of the highest success rates in the industry, right? And nobody even knows who we are, right? So come see, we have a table right out here. Our doors are always open. We've been around for 60 years. We've been in Vermont for what, 13 years now? But we've been around for 60 years. What we do works. So just want to offer that. I'm hearing that, doors aren't open, we can't get in facilities. We don't have a waiting list. Okay? We always have a bed available. I'll sleep on the floor if someone can have my bed to get the help.
Okay, we're running kind of tight on time, and I thought there are several interesting questions that you folks wrote and turned in here prior to that. I tried to group them together. I apologize, we just don't have time to get to all of them. Perhaps we could work out some way where we can get responses to these questions and post them on somebody's website, perhaps the Collaboratives or Fed Up or someone, and we can answer them that way. Get the word up. But there's one group of three here that kind of ties in a little bit to the conversation we've been having here, and I'll just throw all three together, and you can see what we'll see what comes out of that. Are there any long-term, 1 year or longer recovery programs in the state of Vermont? Are there any efforts to educate, expose, or to expand access to Narcan, in rural communities where acute need may be needed. How can we get more treatment centers? If we want to help addicts, we have to open more treatment centers and treat them for a longer period of time. There seemed to be a cluster of questions around the same topic, and I just wondered if any of you wanted to say, I mean, for instance, is there one year-long program available for somebody who might need that kind of help that we know of?
In my experience, that's been one of the great frustrations. To hear about the program that these gentlemen have been talking about is very encouraging. Because what's happened in the time that I've been working in this field is because of managed care, insurance, and a number of other factors, many of our residential facilities have either greatly shortened their stays or no longer exist. The long care treatment facilities that were in existence 15 years ago, most of them are gone. And at a time, I would agree with the idea that for some of our clients, we routinely, like in our staff meetings, we'll see someone and they've resurfaced for the 5th time. They've already been to short-term residential multiple times, sometimes double digits. And our comment is like, there's gotta be a long-term treatment program out there for someone who is struggling this much. But the fact is that the industry has moved away from that. And I don't know all the factors. Those are just some of my limited opinions about what some of the factors are. But I would agree that we need more serious and longer-term treatment for this particular problem because the success rates in treatment are much lower than most of the other drugs that we see. So I do think it needs to happen, but that's a large-scale project that I can't speak to myself.
So in terms of best practice specifically, to address the 1 year or more for medication-assisted treatment, what we know is that for the brain structure and function to recover an opioid use disorder, medication-assisted treatment typically needs to be provided for at least a year for that recovery to occur. And so that is the best practice guidance that we have for the literature for our prescribers for medication-assisted treatment right now.
Okay. Well,
Can you just ask the panel, what do you do if you have a family member, like Wendy was talking about? What do you do if you have a family member that you know is addicted and you know is struggling, but they say, I'm fine and I don't need help?
Boy, that's a tough one. They've got to want to help. They've got to want it. But you need to know that it's tough love. Don't give them money. Buy them food. Hope that they've got a roof over their head, pay for their phone so you can connect with them. But they've got to find that it's tough. And but you don't want them to hit rock bottom either, because rock bottom is dead. So it's a real tough thing. My son, I helped him for a long time, and it didn't help. And when he couldn't stay at my house anymore, and he lived on the street in crummy places. It was a mess. And when he got arrested, I left him in jail. That was a good thing to get arrested, because at least I knew he was safe. So I don't really have the answer to that. I wish there was a place where they can go. In a perfect world, my vision, someday when some rock star gives me lots of money to do this, I want recovery campuses where when they need it, they can go to that part of it to detox. When they're ready, they go to this part. And for a year at least, they go to classes, they learn how to, and they're supported throughout the situation. That's the ideal. We don't have it.
okay.
So can I just add one more thing? I would challenge each and every person in the room to think about what would it be like if our communities were recovery campuses.
There you go. You know, we have to work through our schools and our churches for buildings that are available. They're not used all the time.
Absolutely.
There are 24-hour needs here, not just morning, noon, and dinner time. Not
Sylvia,
7
you know
days
better than
a
I. You're
week.
supposed to go through the moderator.
Excuse me.
Okay, folks, we got time for one more question. I see a bazillion hands up here. My suggestion is going to be, these folks are still going to be here for a few minutes. If you have a question, you absolutely have to ask them, which I'm sure you do. They'll be here. There's also going to be resource materials outside, so the conversation is not over. There will also be more forums, my understanding is, like this following up. This gentleman over here by the wall has had his hand up for about half an hour, so you're the last one.
Joel Ariel, I'm a big fan of Sam Quinones and his book Dreamland. I don't know if that got mentioned earlier. Wasn't here, but I wanted to follow up on this question about insurance companies, because that's my area of expertise, what I can contribute to this community in that discussion. I have a lot of background in insurance regulation, and I work both with insurance companies and providers, and Sam is absolutely right in his book. The insurance companies used to cover a much broader array of treatments than they do today. They've gone to managed care, they've gone to tighter protocols around evidence, but both the AMA, which I'm working with, and the insurance companies, the large ones, recognize an obligation in this area, and so I would just commend to this group to think about ways of proving that different therapies work. You're going to have to get through these bars about, showing that certain things work, but clearly things beyond just medication-assisted treatment, beyond just chiros, beyond just physical therapy. There are all kinds of acupuncture was mentioned, all kinds of treatment options that are working out there, and the more we come together as communities and work on showing how those work, we can get the kind of insurance coverages that are another form of barrier to the right treatment options.
Well, at that point...
One last thing.
Okay.
John Caceres from Valley Vista. I'm actually with one of the treatment centers in Vermont, actually the largest one. And we actually expanded as a result of the closure of Maple Leaf Farm. Just to talk about the contraction of time. We started out, I believe, at one point at being 6 months, perhaps even longer. We're down to really what's been characterized as about a 28-day program. Our program actually has been successful in getting more times for a short-term facility. The problem that we encounter is we're really driven by what the insurance is about. We are a business, whether for-profit or non-profit, it really doesn't matter, but we have to be able to pay our employees, and we can't do that without being funded. Again, whether it's for-profit or for non-profit, we work with places like Teen Challenge as a continuing care base, which is very, very important, because I think it would be arrogant for any treatment center, whether it's 4 to 6 weeks is the case with our adolescent program, or 26 to 28 days or more for our adult programs. It would be arrogant for any of us to think that we can give somebody their recovery. What I like to think of as enduring recovery, because it's not a point in time thing. This is something that requires a daily contact at some level, whether it's with like the folks up here, a Turning Point Center. Peer support has been proven to be one of the best programs that are out there. And that's something that's free. 12-step program, for example. Teen Challenge is awesome. We have worked with them, we've referred people there. It's the continuum of care starts with medically supervised detox. It doesn't just start with detox and then going from that point on, as a lot of these folks know. So it's finding a facility that has a continuum of care that goes from medically supervised detox, which is something that we do, through the aftercare process. And it's not just, hey, go find a psychologist or psychiatrist, an MAT clinic, an IOP program, or a sober living facility. It's working with those individuals, working with folks like these guys, to find out what's going to be the best channel for them to go to, so that they have that continuum of care. They know where to go. They leave with paper in their hand outlining what those appointments are, and that they have the support like Wendy around them that's going to help them to get to those appointments. But then again, as Wendy also said, unless a person wants it, they're not going to get it. And sometimes, as we talk about in recovery, you need the gift of desperation in order to really want it. So, first of all, this is where it all begins, and the support here is amazing. I go to a lot of these things during the course of a month. I participate in a lot of them, and I've never seen a room this full. And this is where it all begins, at the community level. I think we have an expectation, and we're a society that has come to expect that things are going to be done for us. The fact that you all are here says you want to take care of it and take the initiative upon yourselves in order to do this. And that's the only way that this is going to work.
Again, I want to thank Wendy Galbraith, Maryanne Morris, Beth Slawsville, James Riley, and Nissa Walk for being our panelists tonight. I want to thank all of you for coming.